First of all, let me thank you for the opportunity to speak to you about a topic that I consider very important. And obviously, as a surgeon, I'm essentially speaking about the patients that we treat. I'm going to get into some detail about an area that is not truly a surgical area, but one that is vastly important to what we do for our patients. My biography, I believe, is something that you all could probably find somewhere in the archives if you wanted to dig it up. However, it's pretty straightforward. I'm boarded in general surgery, started that way. And about 20 years into my career, I discovered ultrasound and its usefulness in the breast. And from that point on, my practice was devoted to breast surgical oncology. My career in surgery does involve teaching, both at Rush and Loyola, to medical students as well as to residents. As you'll note, I did publish a book on breast cancer management with my co-editor, Mel Silverstein. I have traveled a bit around the world talking, in essence, about breast surgical oncology and the usefulness of ultrasound for the surgeon. My commercial endeavors have been as a medical advisor to a number of companies. The most appropriate or germane to this conference would be as an advisor to Mammoprint and Agendia. One of the most important aspects of breast surgery is not only removing the cancer, but making sure that the proper treatment is administered, because medical therapy is always indicated. One of my pathology instructors, actually a professor in the very beginning of my career, said to me, and it always stuck in my mind, is that pathology is the first step in treatment. And indeed it is. The present dependence upon that analysis resides still with the pathologist and is primarily done in the pathology lab. Unfortunately, I think that because it is done in the lab, there are a number of consequences that relate very closely to the eventual treatment that we administer to patients. That treatment is either going to be a clinical judgment by the surgeon of whether what operation is indicated, and certainly for the medical oncologist, what medical therapy he will deliver to the patient. If tissue diagnosis is the most important basis for what we do, as far as medical or clinical or surgical treatment, then that has to be the pyramid, the base of the pyramid upon which all of this is founded. That pyramid, to me, is a bit shaky. And it's shaky to the extent that because of the way that tissue is examined, and this is through no error of the pathologist, it's because of the process that tissue has to go through in order to be subjectively evaluated by the pathologist. Because of those steps, there can be error along the way in the preparation of the slide or the material for the slide, which eventually is presented to the pathologist as a final product. He will look at that and make a decision on the diagnosis or the severity of that diagnosis. What we have is a system that uses an impaired way to analyze tissue, giving to the pathologist that impaired slide that he will subjectively have to examine. And because of that, I don't think that right today we have an objective way to interrogate a slide and end up with an objective analysis that will be repeatable no matter who looks at that slide. One of the ways that this has been attenuated is through genomic analysis. And genomic analysis today is primarily done by Oncotype and MammaPrint. Unfortunately, even though the results have been very good using this technology, it is very, very expensive and has essentially driven up the cost of care in this country, as well as everywhere else that can afford to have this option for therapy. The results, obviously, are better. However, those results are not available to everyone. And what, unfortunately, we have is the dichotomy of care that's provided to lesser developed countries, different than that here in the United States. Now, as we look at this next slide, the geographic socioeconomic disparities with present-day risk profiling technology, I think that the primary point is that even though these technologies are good and that they're very useful, the cost involved with obtaining these particular treatments, whether it's Oncotype or MammaPrint, in the United States is roughly $3,000 or more. Most patients have either private insurance or governmental insurance that here in well-developed countries will offset the price that a patient would have to pay. Unfortunately, there are societies that don't have that option, that are lesser developed for whatever reason. Since few patients can't afford these tests, then that simply means that doctors who are treating these patients really don't have the information that the genomic tests today can provide in making that treatment incision. Remember, I mentioned that the pathology examination of tissue is unfortunately fraught with errors that can occur related to the process that a slide is put through, or perhaps because of the subjective analysis of one pathologist differing from another. If you allow 100 pathologists to look at the same slide, 70% will agree, 30% will not. That means 30% of patients, if they're treated on that diagnosis, may receive improper treatment. That means that that patient is more liable to recurrent disease in the future. The inability of patients to afford to have a sophisticated treatment like MammaPrint or Oncotype simply means for them either perhaps the wrong medical or chemotherapeutic agent will be delivered, increasing their susceptibility to recurrence, or unfortunately, particularly in lesser developed nations, it means they will have a mastectomy. And as a surgeon, I've always abhorred removing a breast, particularly one that essentially does not need to be removed if they have proper medical therapy. If we delay treatment, say that we're going to send this out, for analysis, and the result comes back in 3 or 4 weeks because of locality, accessibility, then we are also going to have placed upon that patient the possibility of increased recurrent disease. They will not have the same outcome as a patient who is treated immediately or as close to surgery as is possible. Many patients are not able to have MammaPrint or Oncotype used for their particular cancer. I think these are important facts to consider, which I did in actually evaluating Digistain and finding out what it can offer the patient. And one of the things that I found out is that Digistain can essentially give clinicians the same information that is gained from using expensive genomic tests at yet a price that is affordable in many, many other countries across the world, and indeed even to patients who have to pay out-of-pocket expense. I think you'll note that Digistain is much more affordable than standard genomic testing, and more affordable risk profiling would be a boon to patients who either have no insurance or can't afford out-of-pocket expense. Digistain is cost-effective versus that of one of the genomic analyses. What that means is that areas that are not exposed or capable of paying for an expensive test can have the same quality of test performed at a much lower price. This obviously is very important to the government or insurance paying systems, but more importantly, it's the patient. If the family can afford to pay out of pocket for the best possible care of their loved one, their mother, or their daughter or sister, that is certainly a boon to all patients who might incur breast cancer. One of the most important aspects of care, once a diagnosis of breast cancer is made, is the speed at which treatment is delivered. Not only surgical treatment, but indeed medical treatment and radiotherapy today. A loss of time incurred waiting either for the surgeon or the assessment of tissue to find out what chemotherapeutic or endocrine agent to use actually incurs a 10% risk of recurrent cancer for simply 1 month's delay in that analysis. One personal element that we seldom hear about, but I think we surgeons are more prone to hear, is the stress that our patients undergo in having to wait for treatment or the uncertainty that they have, even with their biopsy results. So obviously, stress, patient emotion, and patient outcome are linked to the time it takes to initiate treatment and to continue that treatment, whether it's chemotherapy or endocrine therapy. Remember, recurrence is always possible, and we should try to avoid that for the patient's sake, wherever we can do that. This particular slide that we're looking at now, spectral analysis of unstained breast tissue, really gives an example of the accuracy of the Digistain technique. Because of the way the analysis is done, the errors, the laboratory errors, the human errors, and the machine errors are eliminated. If I had a patient today who had to pay for care out of pocket, given the capacity for a better patient experience and the cost effectiveness of Digistain would be my preferred option. This slide is a demonstration of the effectiveness of Digistain. The patient was postmenopausal, who was ER positive and HER2 negative. She did have a grade 1 tumor, which was 25 millimeters in size, but because she had one positive lymph node, her clinician, her medical oncologist, wanted further guidance on her therapy options. They decided to essentially employ Digistain as the analytical tool. Digistain was used on this patient. Unfortunately, she had to return home. She's the primary caregiver. And using Digistain analysis, the end result is that this patient did have a 14% risk of recurrence, and the physician decided to use chemotherapy for her treatment. She has responded well. This next patient, as you can see illustrated here, had a grade 2 tumor, which was node negative. essentially a typical example of what would normally be sent for genomic testing. The physician did decide to use Digistain, and the patient's report came back with a clear low-risk score, and she was put on endocrine therapy. So here are the key features and advantages of Digistain. Its predictive equivalence is equal to traditional genomic risk scoring analytics. It provides clear insights on the likelihood of breast cancer recurrence within the next 5 to 10 years. It's fast, affordable, provides actionable results, helping to reduce treatment decision times and avoid patient anxiety. Lower cost enables many, many more people in all countries in the world modern analysis if they have breast cancer, a breast cancer diagnosis. One thing that we haven't talked about was the fact that it has a seamless integration with existing clinical workflows, simply because it uses tissue that is not been manipulated at all, other than embedded in paraffin and then de-embedded from that paraffin and placed in the microscope for analysis. And so in summing up the value of Digistain, I can enumerate a number of qualities inherent in the technology. It will improve efficiency in a clinical setting. It will decrease both cost and time for the analysis of the biopsy and the onset of treatment. It's going to decrease anxiety engendered in any patient with the diagnosis of breast cancer, because their answer is going to be given quicker, essentially allowing her treatment to be commenced almost immediately. It will save time from the diagnosis of cancer to the actual onset of treatment. Well, this concludes my remarks on Digistain. Thank you for your time and attention, and perhaps one of these days I'll be able to visit the Philippines myself in person.